Hi, today I'm going to be talking about infections of the nervous system. This will be mostly focusing on meningitis, but we'll also mention encephalitis and some diseases affecting the peripheral nervous system. So first, the anatomy of the meninges. It's made up of three different layers. Firstly, we have the dura mater. The dura mater, as the name implies, is durable and thick, and can be broken down into two different parts. This is the periosteal, which is closely adhered to the bone, hence next to the ostium bone, and meningeal, which means it's closer to the other meninges. And the gaps between these two form the venous sinuses within the skull. Next we have the arachnoid mater, so called because of its appearance with its long spindly fibers. Underneath this we have the subarachnoid space, which is where the CSF sits, and then we finally have the pia mater, and pia means tender, meaning that it's very thin and adhered very closely to the brain. So, meningitis. What exactly is it? Well, as the name implies, it's inflammation of the meninges. It most commonly affects the arachnoid mater, and it can cause damage to itself and irritation of the brain tissue. The infection may also spread to the brain tissue and cause an encephalitis, and that's why encephalitis presents with very similar symptoms to meningitis. However, there are a few differences which I'll discuss later. The meningitis can also easily spread into the blood, and this will then cause a septicemia. And this is the cause of some of the systemic symptoms that people think of when they think about meningitis, such as the rash that's often seen. So there's a number of organisms that can cause meningitis, with Neisseria meningitidis being the most common, and this has different strains including A, B, C, W, and Y, which are commonly vaccinated against. Other things like strep pneumoniae and group B strep, which are common, can cause meningitis. Meningitis B is currently the most common in the UK, however a vaccine for this was recently introduced, so these numbers may change. And it's by far most common in people aged 0 to 12 months. However, other strains have shown peaks in people moving off to university at the age of about 18. The diagram shows the meningococcal belt in Africa, which has a high rate of meningitis. So if you have a patient showing symptoms who's recently visited this area, it's something that you should be considering. So the main symptoms you see in meningitis are a headache with a stiff neck and photophobia. This is because meningitis often affects the posterior part of the meninges. So as the posterior fossa of the skull and its dura are innervated in part by spinal nerve C1 to C3, this gives the neck stiffness. The occipital part of the brain deals with a lot of your vision, hence the photophobia, and the headache will often be across the top part of the head, giving you the common headache seen in meningitis, as it affects cranial nerve 5C, which also innervates this posterior fossa. The systemic symptoms include a fever, which is common due to the immune response mounted to the meningitis, and the non-blanching rash, which is caused once the infection is in the blood and causes rupture of blood vessels in the skin, and this presents as a non-blanching rash, which means if you place a glass to it, the rash will still be present. There are two tests that are sometimes used to try and determine whether or not a patient has meningitis, and they do this by essentially stretching the meninges slightly by extending and shortening the spine. The first of these is Koenig's sign, where you have your patient lying down flat with their thigh flexed up to 90 degrees and their knee also flexed to 90 degrees. When the patient tries to extend their knee, if they have meningitis, then as the meninges try to move over each other, they will have pain. The Brudzinski sign, similarly, you have your patient lying flat on their back, and you gently push up on the back of their head to flex their neck. If the patient then begins to flex their knees involuntarily, then this means that they may have inflammation of the meninges, and this will help the patient to prevent the pain. If you suspect that a patient has meningitis, then the main investigations you should undertake include inflammatory markers and white cell count to check whether or not your patient is showing signs of an infection, blood cultures, as these can be taken to the lab to check whether or not there is anything in the blood and causing a septicemia, and a lumbar puncture, as this allows you to look at the CSF and determine whether or not there is anything present in the CSF that could be causing the meningitis. Before you perform a lumbar puncture, you often want to perform a CT of the head, as this allows you to check for raised intracranial pressure. This is because when you perform a lumbar puncture, you'll create a path to the outside world from the skull. If there is raised intracranial pressure, then this could cause the brain to try and force its way down the spine, and this causes something known as coning. When you perform a lumbar puncture, it's normally performed in the midline between levels L3 to L4, L4 to L5, and sometimes L5 to S1. This is to ensure that you're below the level of the spinal cord termination at L1, L2, and in young children this terminates lower at L3. The layers penetrated when you perform a lumbar puncture are the skin and subcutaneous fat, then the supraspinous ligament, interspinous ligament, ligamentum flavum, extradural fat, the dura mater, and the arachnoid mater. As you pass through the ligamentum flavum, there's a characteristic pop, and then there's another as you pass through the dura mater. Once you've heard both of these pops, you know that you're in the subarachnoid space, as the dura mater is closely adhered to the arachnoid mater. This table shows in the different types of meningitis what differences you'd expect to see within the CSF. So you'd expect to see a raised white cell count in all the different types, and this is due to the immune response that's being mounted. Bacterial infections typically cause a neutrophil response, whereas viral cause a lymphocyte response, as does tuberculosis. In bacteria and TB, the bacteria that are present will be performing transcription, and therefore they'll be producing a large amount of protein. But in doing this, they'll be using up the glucose that's present. So the glucose level will be decreased and the protein will increase. The glucose level is normally considered low if the glucose in the CSF is less than half of the glucose present in the blood. In order to treat meningitis, you first want to consider if the patient has sepsis, and then you'll give the sepsis 6, which I remember as give, take, give, take, give, take. You start by giving high flow oxygen, and you then take blood cultures. You then give broad spectrum antibiotics, and you want to make sure that you take blood cultures before this step, otherwise you may lose the culture as you have used the antibiotics to treat the infection. You then take serum lactate, you give IV fluids, and take accurate urine measurements. In bacterial meningitis, you typically get, hello, I wasn't talking to you. In bacterial meningitis, ceftriaxone, which is a very strong antibiotic, is often given for 1 week and is paired with dexamethasone, which is a glucocorticoid. Prophylactic treatment is then given to household and kissing contacts, as these are the people who it's most likely to spread to. Now moving on to encephalitis, which is inflammation of the brain tissue. This is most commonly viral, and this is one of the key differences from meningitis. And the most common viruses causing it are the herpes simplex virus and HIV. It presents very similarly to meningitis, but one of the key differences is that the patient will often have rapidly worsening confusion, and they may become agitated and aggressive. The patient also often shows more focal CNS symptoms, so this depends on where the inflammation is affecting. So if it's affecting their occipital lobe, then they may be presenting with visual deficits, whereas if it's affecting their temporal lobe, they may have auditory deficits. It's investigated in much the same way as meningitis, but is commonly treated with acyclovir, as this is an antiviral treatment. The herpes simplex virus is commonly known as a sexually transmitted illness. The HSV1 type is typically your oral herpes, and HSV2 is typically your genital, although they can both infect both the mouth or the genitals. Initially, the infection takes place, and it's common to have a significant first reaction, and you'll have the classical herpes blisters appearing. The infection can then track back along the nerves to the ganglia. So in HSV1, this typically tracks back to the trigeminal ganglion, where in HSV2, this will track back to the dorsal root ganglion. When the body becomes immunosuppressed or you become stressed, then this infection can reactivate and then cause further swelling and blisters in the area. And this is what's commonly thought of as either herpes labialis, which is around the mouth, or herpes genitalis, which is genital herpes. The varicella-zoster virus is commonly known as chickenpox. It normally first presents with ulcers and blisters, which cover much of the body. After this initial presentation, the ganglia, again the trigeminal or dorsal root ganglia, may become infected, and the infection can remain there latent. At a later date, when the patient becomes stressed, this infection can recur, and it will typically only recur in one area, as it's only remained in one ganglion. This means that its recurrence has this dermatomal pattern, so it will typically follow one of the dermatomes of the body, and it will show up with a rash and blisters, which are itchy. So that's everything that you need to know about the infections of the nervous system. Thank you.